perspective. Actually, my talk is going to be just a continuation of Dr. Abdullah Sharm's excellent talk, and we'll just spice it up with the pharmacoeconomic perspective, which is the clinical, humanistic, and economic value. So these are my outlines. We'll talk about epidemiology of renal cell carcinoma. We'll discuss the risk stratification model for the prognosis of the advanced RCCs. We'll discuss the international guidelines for the management of the kidney cancer, and we'll discuss the previous standard of care for the management of the advanced RCC, and we'll discuss also the newer standard of care, which is the combination therapy for the first-line treatment in advanced RCC. We'll discuss the landmark trials, which have already been presented by Dr. Abdullah Sharm, which are the basis of the recommendation of the combination therapies in the international guidelines. We'll also talk about the humanistic value, which is also one of the perspective of the pharmacoeconomic analysis. And lastly, we'll talk about the cost effectiveness analysis. So let's go to the epidemiology of the renal cell carcinoma. This was the report presented in one of the open access research journal about the global trends and projection of the kidney cancer. In 1990, there were nearly 200,000 of the newly diagnosed kidney cancer patients worldwide per year, which had been double in the next 27 years. By year 2017, the incidence of the newly diagnosed renal cell carcinoma was increased to 400,000 globally. And this incidence is expected to increase up until 2030, and it's projected to the incidence is increased to 475,000 new cases in year 2030. Now let's have some statistics from Saudi Arabia. We have Global Cancer Observatory report of Saudi Arabia, which was published in 2018, and according to this report, kidney cancer is the 10th most common cancer in Saudi Arabia in 2018. The incidence of the kidney cancer in 2018 was 830 cases, and mortality was nearly 250 in 2018. And the 5 years prevalence for all ages was 2,300. And the kidney cancer is more common among the males in comparison to female, with a ratio of 2 to 1. Now let's go to the risk stratification model. I think we are familiar with the older risk stratification model, which used to be Memorial Sloan Kettering Cancer Center, which is obsolete now as it was validated based on the older standard of care, interferon-based chemotherapy regimens. The new risk stratification model is called IMDC model. It is validated based on the newer standard of care, Sunitinib, Sorafenib, and Bevacizumab plus interferon. And actually, I'm expecting a new standard of care in future, because as we go along our presentation, we'll see the combination therapy using immunotherapy-based combination has significantly improved overall survival in comparison to relatively older standard of care, Sunitinib and Sorafenib, which was standard of care up until 2018 guidelines as per NCCN recommendations. So there are 6 criteria for IMDC risk stratification model. 2 of them are clinical criteria: low prognostic performance status less than 80%, and the time from the initial diagnosis to systemic therapy of less than 1 year is the clinical criteria. And the laboratory, there are 4 laboratory criteria, which is anemia, hypercalcemia, neutrophilia, and thrombocytosis. So in patients who have no risk factor, there's favorable risk. 2 years overall survival was expected to be 75%, and in intermediate risk, overall survival is dropped to 53%. And poor risk patients, which has 3 to 6 risk factors, overall survival is further declined to 7%. But actually, you will see in the combination therapy, this overall survival has been significantly improved in combination therapy. Let's have a quick glance at the treatment landscape for the advanced RCCs and metastatic renal cell carcinoma. I was born in oncology when there was no Sorafenib and Sunitinib, which remains standard of care for a couple of decades, 1.5 decades, I would say. So we used to have interferon before 2005, and then we had Sorafenib in 2005, followed by Sunitinib next year, followed by temsirolimus next year, and we have the Bevacizumab interferon-based combination. Everolimus was also approved second line, and Pazopanib was also approved in 2010. We had another TKI approved in 2013. It was Axitinib, and then in 2015, first ever immunotherapy was approved for our advanced RCC in second line after the failure of Sunitinib, that was Nivolumab. And then we had Cabozantinib approved the same year. Everolimus and Lenvatinib combination was approved also in a similar year. So basically, Sunitinib, as Dr. Abdullah mentioned, has been standard of care up until 2018. Then we had the approval of first ever combination immunotherapy-based combination Nivolumab and Ipilimumab in 2018, followed by two more new combination immunotherapy-based combination in 2019, which were Pembrolizumab and Axitinib, and Avelumab and Axitinib. So they have basically completely knocked down Sunitinib and Pazopanib from the treatment landscape of metastatic renal cell carcinoma. And have a look at the newer NCCN guidelines, 2021, version 1. So if you look at the favorable risk advanced RCC, we have three preferred regimens: Axitinib and Pembrolizumab is there, and Pazopanib and Sunitinib are preferred regimen, but they're not category 1 recommended treatment option anymore, and their placement has been displaced by Axitinib and Pembrolizumab have been included into the guidelines of the favorable risk advanced RCC. And we have for intermediate risk, we have two category 1 and preferred regimen, which is Ipilimumab in combination with Nivolumab and Axitinib in combination with Pembrolizumab. Both of them are category 1 recommended treatment option. You can have a look at the Pazopanib and Sunitinib that have been displaced from the category 1 recommended preferred regimens to other recommended regimens with category 2A recommendations. Now, let's have a quick look at the standard of care therapy for the advanced RCC before the era of the Immuno Oncology I'm talking about before 2018. So we used to have Sunitinib, and we still have Sunitinib and Pazopanib. Actually, these both of them are VEGF tyrosine kinase inhibitor. Sunitinib is used 50 milligram daily, 4 weeks on, 2 weeks off, and Pazopanib is used 100 milligram once daily, uninterrupted until the disease progression. There are some differences in the toxicities of Sunitinib and Pazopanib. Sunitinib is more known to have Hanford syndrome and stomatitis, whereas the Pazopanib is more known to have hypertension and transaminitis, and Hanford syndrome is lesser with the Pazopanib. These are the two randomized controlled trial, landmark trial for Sunitinib and Pazopanib respectively. And this randomized control trial for Sunitinib was published in New England Journal of Medicine in 2007, where the Sunitinib was compared with interferon. And if you compare the baseline characteristics of this trial with the Keynote 426, very similar in terms of the favorable risk patients and intermediate risk patients. But in Checkmate 214, the favorable risk patients were slightly lesser than what we have seen in this trial. And that's why you will see the differences in the overall progression-free survival in this study as well as in Keynote 426 study. So in this randomized control trial, progression-free survival was significantly superior with Sunitinib 11 months versus 5 months in interferon with a hazard ratio of 0.42. Overall survival was also significantly superior with Sunitinib 26 months versus 21 months in interferon with a hazard ratio of 0.65. And the COMPASS trial, Dr. Abdullah already presented today. It was a non-inferiority based study comparing the non-inferiority of the Pazopanib with the Sunitinib in a randomized phase 3 control trial. Again, it was published in New England Journal of Medicine. By the way, most of the randomized control trial in RCC were published in New England Journal of Medicine. And again, the progression-free survival and overall survival, the purpose was to establish the non-inferiority, and they were non-inferior in terms of the progression-free survival and overall survival. Sunitinib and Pazopanib were pretty similar to each other. I wanted to take your attention on this slide, which is the previous NCCN guidelines 2018's version 1. And according to the recommendation of the NCCN 2018 version 1, you can see Pazopanib, Sunitinib, Bevacizumab, they were category 1 recommended treatment option in advanced RCC, but not anymore, because after the inclusion of the combination therapy, they have been dropped from category 1 recommended treatment option to preferred regimens in favorable risk and category 2A recommended treatment options in intermediate poor risk advanced RCC. So that's what I was referring to. Sunitinib is preferred category 2A recommended treatment options, and also the Pazopanib is preferred category 2A recommended treatment option in favorable risk, but they are dropped to category 2A in intermediate poor risk advanced renal cell carcinoma. Now let's get into the new era, which is the standard of care therapy has been changed from Sunitinib, Pazopanib to Immuno Oncology based combination therapy. Let's see the standard of care in this era of Immuno Oncology. So we have 3 combination immunotherapy based combinations. We have Nivolumab and Ipilimumab. We have Pembrolizumab and Axitinib. We have Avelumab and Axitinib. So Nivolumab and Pembrolizumab, they are PD-1 inhibitors, and Ipilimumab is CTLA-4 inhibitor. Whereas Avelumab work on PD-L1 ligand, which is in the tumor, and Axitinib is VEGF tyrosine kinase inhibitor. We're going to talk about the mechanism of action with the illustration of the pictures. So this slide basically provides the conceptual basis of combining immunotherapy-based combinations. So, you know, in order for the tumor cell to have immune, in order to have tumor development, it needs to have tumor escape mechanism. So tumor try to develop immune escape mechanism by exhaustion of the T cell, by the expression of the PD-1, PD-L1, CTLA-4, and VEGF. That's the conceptual basis of combining PD-1 with CTLA-4 or PD-1 with VEGF tyrosine kinase inhibitor, or PD-L1 with the VEGF tyrosine kinase inhibitor. Regarding the question of Dr. Muhammad Al-Nahid, why do we compare with Sunitinib? Yeah, I think it's okay to compare with Sunitinib because Sunitinib has been the standard of care treatment of an advanced RCC. However, why they have chosen Axitinib, that's a totally political question. I agree with Dr. Abdullah. Okay. So, you know, VEGF also plays an important role in the development of immunosuppressive microenvironment by pro-angiogenic mechanism, and VEGF tyrosine kinase inhibitors such as Sunitinib or Axitinib, and they can reverse this state by anti-angiogenic mechanism, and they can improve the immune system microenvironment. So now let's try to understand the mechanism of action of PD-1, PD-L1, and CTLA-4 inhibitors. So we know that PD-1 inhibitors such as Nivolumab and Pembrolizumab, they basically work on the PD-1 receptors in the T cell, and they block this interaction between PD-1 with its ligand PD-L1 in the tumor cell. And as a result of this blocking this interaction, the T cell function is restored and anti-tumor immune response is improved. Whereas the Avelumab, which is PD-L1 inhibitor, it works on the tumor cell, it works on the ligand, and it prevents the interaction between the PD-L1 with its PD-1 receptor in the T cells, and also PD-L1 interaction with the B7 or CD80 receptors in the antigen presenting cell, and the dendritic cells are also inhibited, and as a result of that, T cell function is restored and anti-tumor immune response is improved. Well, the anti-CTLA-4, which is Ipilimumab, its mechanism of action is really interesting, and it's unique, and it's different from PD-1, PD-L1 inhibitors, and that tells you the basis of the reason why we can have synergistic activity from combining anti-CTLA-4 with PD-1 or PD-L1. So in order to understand the mechanism of action of Ipilimumab, we need to understand some definition. TCR is the T cell receptor, which is expressed in T cell, and that's responsible for recognizing the fragments of the antigen in major histocompatibility complex. CD28 is expressed in T cell as well, and that's co-stimulatory signal for T cell stimulation, T cell activation, and survival. But the T cell activation that happens through TCR and CD28 results in the production of significant amount of interleukin, particularly IL-6. But at the other hand, CTLA-4, which is the downregulator of the T cell, it binds with the B7 or CD80 receptor in the antigen presenting cell and results in inactivation of the T cell. So that's where the role of the Ipilimumab comes into action. It blocks this interaction between CTLA-4 and its B7 or CD80 receptors in the antigen presenting cell and improves the T cell function. So that's why combining Nivolumab with Ipilimumab results in enhanced T cell function that is greater than that of either antibody used alone, result in improved tumor responses we have already seen in metastatic melanoma, and now we have seen in advanced renal cell carcinoma. So Dr. Abdullah also talked about this 3 randomized controlled trial, Checkmate 214, basically used a combination of Nivolumab and Ipilimumab, 3 milligram per kg Nivolumab plus Ipilimumab 1 milligram per kg used every Q3 weeks for 4 doses, and then Ipilimumab was discontinued, and monotherapy Nivolumab 3 milligram per kg was continued Q2 weeks, or you can use even 6 milligram per kg, using weight-based dose of nivolumab is most cost-saving strategy, in my opinion, and we have already started implementing this in Ministry of National Guard Health Affairs, which saves at least 100,000 reals per patient per year. Or you can use the flat dose of 240 milligram Q2 weeks or 480 milligram every 2 weeks. And the control population in all 3 trials used sunitinib 50 milligram daily, 4 weeks on, 2 weeks off fashion. The primary endpoint in the Checkmate 214 were progression-free survival, overall survival, and response rates, overall response rates. Javelin Renal 101 trial has evaluated Avelumab in combination with Axitinib and compared with Sunitinib in a randomized control trial fashion. And primary endpoint was progression-free survival and overall survival in PD-L1 positive patients. Whereas Keynote 426 study have compared Pembrolizumab in combination with Axitinib versus Sunitinib, and the primary endpoint for progression-free survival and overall survival. So now let's have a look at the finding of Checkmate 214 study, which was published in New England Journal of Medicine in 2018, which compared nivolumab versus sunitinib, nivolumab Ipilimumab combination versus sunitinib. The baseline characteristics were well balanced between these 2 groups, and favorable risk patient with 23% in 214, whereas in previous sunitinib randomized control trial, which was published in 2007, it was 38%. In Keynote 426% was also more than 30%. That probably will have some kind of influence on progression-free survival and overall survival as well, especially in the control arm. So in progression-free survival in intermediate poor risk patient with the 48 months follow-up was 11.2 months with the combination arm versus 8.3 months. And this 48 months follow-up was presented by Dr. Lawrence Selvages in ESMO 2020, which was a couple of weeks ago, and they found that the reports are consistent with the previous reports of the progression-free survival. And at 48 months, progression-free survival was curve was plateaued at 35%. And overall survival at 48 months follow-up was 53.4% in combination arm in ITT population versus 43% in sunitinib. And in intermediate poor risk patient, the 4 years overall survival was 50% in combination versus 35.8% with a hazard ratio of 0.6. In Keynote 426 randomized control trial, which was published again in New England Journal of Medicine last year, it compared Pembrolizumab Axitinib combination versus sunitinib. The baseline characteristics were very well balanced. Progression-free survival was again better in the combination arm, 15.4 months versus 11 months in sunitinib, with a hazard ratio of 0.71. And overall survival at 2 years, 2 years follow-up was presented by Elizabeth at ASCO this year, 2020. So 2 years overall survival in intention to treat population was 74% in combination arm versus 66% in sunitinib with a hazard ratio of 0.68. And 2 years overall survival in intermediate poor risk population was again better in the combination arm, 69% versus 56% with a hazard ratio of 0.63. Then we had Javelin Renal 101 trial, which was published again in New England Journal of Medicine. There's a specific association with all these trials in New England Journal of Medicine, by the way. And this randomized phase 3 control trial compared Avelumab in combination with Axitinib versus Sunitinib. And again, the baseline characteristics were very well balanced, but the favorable risk patient percentage was very similar to Checkmate 214, and it's much lesser than Keynote 426. The progression-free survival was again better in combination arm in Javelin, in the combination arm, 38.8%, 13.8 months versus 8.4 months in Sunitinib with a hazard ratio of 0.69. And overall survival was not yet mature to be reported in Javelin Renal 101 trial. Now, Avelumab is not registered in Saudi FDA. Pembrolizumab and nivolumab are registered in Saudi FDA, so I'm trying to compare and contrast Pembrolizumab versus nivolumab-based combination with regards to the cost effectiveness, the pharmacoeconomic perspective. We have already gone through the study design of the Checkmate 214, which compared nivolumab plus Ipilimumab versus Sunitinib. So the 48 months follow-up of Checkmate 214 was presented in ESMO by Alvages a couple of weeks ago. This is the longest ever follow-up with any immunotherapy-based combination that was presented up until now. So immunotherapy-based combination, nivolumab and Ipilimumab was found to have significant overall survival benefit at 48 months follow-up, regardless of the risk stratification. So the median overall survival in the ITT population was not yet reached in the combination versus 38.4 months with Sunitinib and the hazard ratio of 0.69. And similarly, intermediate poor risk patient, the median overall survival was higher, 48 months versus 26 months in Sunitinib, and almost double from Sunitinib. And the hazard ratio of 0.65. You can see the curves were very well separated, and they remain separated up until 48 months, and the responses are ongoing. Then we have the subgroup analysis of the overall survival among the IMDC intermediate and poor risk patients. So in all the subgroup, the outcomes were favoring Nivolumab, Ipilimumab combination in comparison to Sunitinib. And we have the progression-free survival data, which was presented again by Albiges at ESMO 2020 a couple of weeks ago. And they found that the reports are consistent with the previous report with regards to progression-free survival. There was no difference in terms of progression-free survival in ITT population, but in intermediate poor risk population, median progression-free survival was 11.2 months in the combination versus 8.3 months in Sunitinib with a hazard ratio of 0.74. And they also found that the curves were plateaued at 35% at 48 months follow-up. We definitely need a deeper response rates, such as complete responses and partial responses, which can predict the overall survival. So Albiges presented the best overall confirmed responses per RECIST 1.1 in ITT population, as well as in intermediate and poor risk and favorable risk population at 48 months follow-up. So we have seen that in ITT population, as well as in intermediate and poor risk population, the complete responses with the combination arm was approaching 10% or 11%. Versus 1 to 2% in Sunitinib, which is huge. And also the partial responses were better with the combination therapy in comparison to Sunitinib. This is a very important slide, which talks about the duration of the confirmed responses. So what we have seen at 48 months follow-up, Albiges presented at ESMO 2020, that the median duration of the responses were significantly longer, regardless of the risk stratification. In ITT population, the median duration of the response is not yet reached, versus Sunitinib was 23.7 months with a hazard ratio, very impressive hazard ratio of 0.51. And intermediate poor risk patient, the median duration of the responses are not yet reached versus 19.7 months in Sunitinib with the hazard ratio of 5. You can see the curves very well separated and the responses are ongoing. And there is a cost effectiveness, hidden cost effectiveness value of this prolonged duration of responses, and which we'll later talk about in, when it comes to the cost effectiveness analysis. Now let's discuss some of the side effects. The dark gray color is representing grade 3 to side effects in Sunitinib arm, and dark green color is representing grade 3 to 4 side effects in Nivolumab and Ipilimumab arm. So diarrhea, fatigue, hand-foot syndrome, and hypertension, these were more common with Sunitinib, whereas pancreatitis was more common with Nivo-EP combination versus Sunitinib. And overall, Nivo-EP combination was well tolerated, and median duration of the responses was 8. Median duration of the treatment in Nivo-EP was 8 months, and also Sunitinib was continued for 8 months in Checkmate 2. That's an interesting post-hoc analysis which was presented by Dr. Nizar last year in ASCO. So he found that those patients who discontinued Nivo-EP combination due to adverse related events, they actually had better overall survival. If you look at the 42 months follow-up, which was presented last year in ASCO, those patients who had adverse events and they discontinued Nivo-EP combination because of the adverse event, they actually had better overall survival better than to ITT population, 66% in those patients who discontinued therapy versus 56% intention to treat. This study actually tells you, this analysis actually tells you that many patients, they had treatment-free survival benefit or treatment-free responses, and that has a very significant, cost effectiveness value. So because those patients who progressed are they require in Sunitinib and they require the subsequent lines of therapy. They have to use Nivolumab and other lines of therapy. So you will see like those patients who responded who discontinued only due to adverse related events, they actually had better cost per respondent, and cost per response per month will present in one of the studies. Humanistic value, which is health-related quality of life, is also an important pillar of the pharmacoeconomic perspective. So FKSI 19 is one of the quality of life metric used in kidney cancer patients. FKSI was similar at the baseline between the two groups, but then at each assessment during the first 6 months, the mean change from the baseline was much greater in the favor of Nivolumab and Ipilimumab. So that shows you that patient has reported better health-related quality of life in combination arm as measured by FKSI 19 score in comparison to Sunitinib. Now let's move to the Pembrolizumab Axitinib trial, which is Keynote 426 study. We have already discussed the design. So 2 years overall survival data was presented by Dr. Elizabeth Pulmack at ASCO this year. And at 24 months, the overall survival was significantly better. In the combination arm, 74% versus 66% with Sunitinib, hazard ratio of 0.68, very good hazard ratio. And in those patients who were having intermediate and poor risk, 2 years overall survival was 69%. In combination arm versus 56% with hazard ratio of 0.63. You can see the curves were separated, and still the response is ongoing. Progression-free survival, 24-month survival data was presented in ASCO 2020. So the progression-free survival was 15.4 months in combination arm versus 11.1 months in Sunitinib with a hazard ratio of 0.7. Confirmed overall responses were also better with the combination arm Pembrolizumab Axitinib. The complete responses were 8.8% with the combination versus 3% with the Sunitinib, and also partial responses were better with the combination in comparison to Sunitinib. And the duration of the response also was better in Pembro Axitinib versus Sunitinib, 23.5 months versus 15 months. And this is overall survival, progression-free survival, and overall response rate in IMDC favorable risk advanced RCC patient. There's not much big difference in overall survival and progression-free survival between the two arms, but overall response rate was significantly better in the combination arm versus the Sunitinib. Whereas the overall survival, progression-free survival, and overall response rate were significantly better in IMDC intermediate and poor risk advanced RCC. You can see the clear separation of the curves in overall survival between the two groups with impressive hazard ratio of 0.63. Progression-free survival also was significantly better. The clear separation of the curve, hazard ratio of 0.69. Overall response rates were also better with the combination. Now, the grade 3 to 5 side effects are listed on this slide with the dark green color, and dark green color is actually Pembro Axitinib grade 2 to 5 side effects, and the dark red color is representing grade 2 to side effects of Sunitinib. So you can see diarrhea and hypertension were more common with Pembro Axitinib. Hand-foot syndrome is more common with Pembro Axitinib. That's the class effect of VEGF TKI. Axitinib and Sunitinib both have hypertension and hand-foot syndrome. Fatigue was more common with Sunitinib, and transaminitis was more common with Pembro Axitinib, whereas thrombocytopenia and neutropenia were more common with Sunitinib. So now I would like to quickly have your attention on the trend of the hazard ratio, what happens over time with the hazard ratio in Checkmate 214 trial and Note 426 trial. So we have 30 months follow-up data and 48 months follow-up data, which for 30 months data follow-up data was presented in ASCO GU last year. And overall survival in ITT population had a hazard ratio of 0.71, which improved over time to 0.669 at 48 months follow-up, which is really impressive, and that shows you the median duration of the response is ongoing. Actually, it's 48 months, and it's not yet reached in the ITT population in Checkmate 1.4. Whereas the overall survival in favorable risk was not significant at 30 months follow-up, but at 48 months follow-up, it has improved. Hazard ratio is improved to 0.9. Whereas what happened with the hazard ratio in Keynote 426 over time, it actually got worsened. In ITT population, 7 months data was presented in ASCO GU last year. The hazard ratio was 0.53, and at 23 months follow-up data, which was presented in ASCO this year, the hazard ratio has worsened to 0.68. Whereas in favorable risk, overall survival hazard ratio was 0.64, very impressive and significant, but it lost its significance over time. At 23 months follow-up, it was worsened to 1.06. So now let's move to the last part of our presentation, which is cost effectiveness analysis. So basically, we are comparing Nivolumab, Ipilimumab, and Pembrolizumab and Axitinib, especially in intermediate and poor risk advanced RCC. So in first year, you have to use Nivo in combination with EP. So the cost of the first year is 452,000 reals versus the cost of the Pembrolizumab and Axitinib is 608,000 reals for the first year, and the same is the cost for the next year for Pembrolizumab and Axitinib. But the cost of the Nivo Ipilimumab is reduced to 407,000 for the second year, as there's no Ipilimumab next year. So the 2 years cost is 859,000 for Nivo Ipilimumab, and is 1.2 million reals for Pembrolizumab and Axitinib. If you look at the cost difference, 2 years is 357,000 reals in favor of Nivolumab and Ipilimumab. But what actually I do in my clinical practice, I try to use weight-based dosing of Nivolumab. There was a study published in January this year, which actually have shown if you use alternate dosing strategies for Pembrolizumab and Nivolumab, you can save significant amount of money. So, and most of the patients in my center for different cancers, their weight is less than 70 kg. So in those patients using weight-based dosing, you can save almost 100,000 reals per patient per year. So if I add this value to the cost difference in 2 years flat dose, so we're going to save additional 200,000 real per patient per year. So we're talking about the cost difference of in the excess of 500,000 real per patient per 2 years. But actually, this is just approximate, cost calculation. That's not true, because in Checkmate 214, the median duration of the treatment with Nivo EP was 8 months, and Sunitinib was 8 months. And Pembrolizumab, Axitinib, median duration of the treatment was 10 months, and the control arm had 8 months duration of treatment, Sunitinib. If you use this median duration of the treatment for the cost comparison, and you use weight-based dosing, so we are talking about 267,000 reals for the Nivo EP combination in Saudi Arabia versus Pembrolizumab, Axitinib is going to cost about 569,000 reals. So we are talking about 300,000 real per patient cost saving if you use weight-based dosing in the favor of Nivolumab, which is very significant in terms of saving the money and resources especially for the government healthcare institutions. We have to also compare and contrast with the older standard of care, Sunitinib and Pazopanib. Actually, they are still the standard of care for favorable risk advanced RCC. So the cost of Nivo EP we just discussed is 267,000 reals, and that of the Pembrolizumab is 569,000 reals for 10 months duration, and Sunitinib is going to cost around 100,000 reals for the duration of 8 months treatment, and Pazopanib is half of the cost of this. This is the study I was talking to you earlier that was presented it was a poster presentation, was presented in Annual Society for Immuno-therapy of Cancer meeting in November 2018 in Washington, D.C. have shown they have taken the data from Checkmate 214, and they found that those patients who were responding in Checkmate 214, they found that the those who used combination therapy and those who were responding, they actually had lower cost per responder and lower cost per month versus Sunitinib. So have a look at the the graphs here, the green bar is representing Nivo EP, and the dark gray is representing Sunitinib. And you can see that the cost per responder is lower in Nivo EP combination, and it improves over time. And if you look at the right column with this cost per month per response of the Nivo EP has been shown versus Sunitinib, there's significant difference in terms of cost saving in the favor of Nivo Ipilimumab with the significant p-value of 0.01 at 2 years follow-up and over available follow-up period of 0.0014. You can see the cost per month per response was $38,000 in combination arm versus $53,000 in Sunitinib. So what happens basically, those patients who are taking Sunitinib, so when they progress, they cannot require subsequent lines of therapy. They will receive Nivolumab, they will receive everolimus and other lines of therapy, and that's why the cost per month per response is higher in Sunitinib arm, whereas many patients who discontinue therapy in Nivolumab, Ipilimumab combination, they remain treatment-free responses or treatment-free survival. That has very significant hidden cost-saving value when you do the pharmacoeconomic evaluations. So that happened because there was we discussed that there was prolonged duration of responses in Checkmate 214, which is not yet reached in intention to treat population, versus Sunitinib was around 21 months, and that basically is translated into lower cost per response and cost per month per response over time, and that is also being considered by NICE guideline when they evaluated Ipilimumab in combination with Nivolumab. So they found this is a cost-effective strategy, cost-saving strategy. NICE guidelines are really tough on approving drugs. So we thought the acquisition cost of Nivo EP is much more financially toxic than Sunitinib. But actually what happened over time, so those patients who receive Sunitinib first line, they can require subsequent lines of therapy. So the NICE evaluation, they found that if you use Nivo Ipilimumab in first line advanced RCC in intermediate poor risk patients, so this is more cost effective strategies, cost saving strategy in comparison to other lines of treatment. And that's not what happened with Pembrolizumab and Axitinib by NICE guideline. Nivolumab and Ipilimumab have been listed as cost-effective strategy in many HTA authorities in different countries, such as Canada, Australia, and UK. So with regards to the Pembrolizumab and Axitinib, that has been rejected by NICE guidelines because of a couple of reasons. First thing, they are not certain that there is a long-term benefit with Pembrolizumab and Axitinib because only 2 years data is available in comparison to Checkmate 1.4. We have 4 years data available. The second factor is that whatever the duration of the responses are there, whether this is, there's a long-term benefit associated with the Pembrolizumab and Axitinib, they are saying the cost of the Pembrolizumab and Axitinib is exceeding the threshold ICER, which is considered appropriate for the approval of drugs from the NHS resources. So they're saying this is exceeding the ICER threshold, in the UK, and the GDP power purchasing parity is $40,000, and that's what the ICER threshold is, and it's much more higher than that in order to, NHS. So now we conclude for favorable risk advanced RCC. I think Sunitinib and Pazopanib are preferred regimen in NCCN guideline, and we have shown that they are more cost effective in comparison to Pembrolizumab and Axitinib, which is also one of the preferred regimen in NCCN guideline. And if you would like to ask me which one to choose from Sunitinib and Pazopanib, I always favoring Pazopanib is more cost effective because it is the half of the price of Sunitinib, and in COMPARES trial, which represents the quality of life reported by the patient in Pazopanib was superior in Pazopanib in comparison to Sunitinib. And if you would like to ask which one is more cost effective in intermediate and poor risk advanced RCC, from the NCCN guidelines 2021, you have two options, either to use Nivo EP combination or Pembrolizumab combination. Both of them are category 1 recommended treatment option. So you can choose any one of them, which one is cost effective for your country or for your institution. But the exercise that we have done just now, and the exercise that this is done by the NICE guideline and other HTA authorities in different countries, and one of the poster presentations that I've shown you from one of the Immuno Oncology meeting that use of Nivo-Ipi combination is more cost-effective in comparison to Pembrolizumab and Axitinib. And one of the advantage of the Nivo-Ipi combination is that you use this combination only 4 cycles, and then you have to stop Ipilimumab and continue monotherapy with the Nivolumab. Whereas Pembrolizumab and Axitinib combination, you have to use the combination up until disease progression or acceptable toxicity. So this is the conclusion. So for favorable risk advanced RCC, we can use Pazopanib or Sunitinib, whichever is cost effective in the first line advanced RCC. I would suggest to choose Pazopanib over Sunitinib, and for intermediate poor risk advanced RCC, Nivolumab and Ipilimumab is found to be cost effective immunotherapy combination in this group from the exercise that we have done. These are the guidelines from Saudi FDA for minimization of the risk of Nivolumab and Ipilimumab. And with that, thank you so much for your.